Good evening. It's now 6 o'clock, and I'm going to hand over to Dr. Norikido. Thank you.
Good evening, and thank you very much, Renee. Good evening, colleagues, and on behalf of the South African Medical Association, I would like to welcome everyone to this evening's webinar. We will be discussing a topic that I think is very, very important, and it's something that affects your pocket directly, and that is your salary as doctors. SAMA believes that the compensation of doctors, and in fact that of healthcare workforce in general, is a critical component in ensuring the sustainability and the effectiveness of our health system. Over the past decade, the South African health system has gone through quite a number of significant changes, challenges, and even victories. And amidst these transformations, one crucial aspect which SAMA notes as very, very important and needs a constant review is that of the remuneration of medical doctors. The OSD, or what is referred to as your occupational specific dispensation policy, has been instrumental in shaping and creating career pathways for doctors. However, the question remains, and that's at the point of discussion tonight, that whether these earnings have kept up with the economic realities that we face today, and especially in terms of the inflation. So the main objective of tonight's engagement is to really unpack the trends in terms of doctors' salaries over the last 10 years. And to analyze this, we however want to check how they fared in relation to the inflation rate. So our experts will discuss and debate and propose measures to ensure that doctors are fairly compensated for their valuable contribution to society. So without wasting any time, colleagues, let me take this opportunity and introduce to you our first speaker, who is the summer board member, Dr. Sizeka Maweya. Dr. Maweya is going to give us a historic overview of the OSD. Dr. Maweya, the floor is yours, sir.
Thanks very much, Dr. Notikida, and everybody else who is in this discussion, this very important discussion this evening. I'll start off by saying that OSD actually, the discussion started somewhere around 2007 or so. Then in 2009, it became really like a really bone of contention for us as doctors. When we realized that whatever we envisaged for was never done. The aim of the OSD at the beginning for us as doctors was to improve our salaries and also for retention of doctors in the public sector. That was the whole aim. Then from there, we realized that that aim was actually being dashed away by politicians because nobody was listening. Until in 2009, we decided to take it upon ourselves, whereby we even came up with a slogan that if you want to pay peanuts, you rather employ monkeys, and which was actually our slogan. And most of our posters were talking to that. Then we realized, how can we then improve our salaries? We then had to go to a bargaining chamber. Unfortunately, in the bargaining chamber, we had to be with everybody else, and you needed at least 20,000 to get one seat. However, DINOSA was very actually generous. They gave us seats to actually be part of that bargaining chamber. But as we're there, we realized that we're actually lumped up with almost everybody, the cleaner, the gardener, and everybody else. And we are talking about these big monies, and then people were actually surprised. But at the end of the day, they were very sympathetic to us when we told them that how much a doctor is earning. It made a very big impact in 2009 because we're united and they could see that we're working so hard. We got public sympathy, which actually was the chip for the toying for the salaries. However, then when we're there, we even thought from outside when we're sending people to negotiate on our behalf to say, why can't we negotiate like pilots, like judges? We have our own discussion, but nobody was listening. And when it was implemented, it came like a shock of our life, like what Dr. Notikida have said. We'll actually have some graphics to show the discrepancies which came in. What we realized was that it was only the interns and the heads of departments who were actually addressed. The missing middle was our workforce, which is the medical officers, which are the core of healthcare that everybody knows in terms of, because medical officers are the ones who run the district hospitals, they run the regional hospitals, they run almost every part of our hospital. They are in the majority, but these people were actually left out. And then they only address the interns and also the head of departments. The reason was the interns were, the government thought they were very clever because the interns actually is on contractual basis. And then from there, the head of departments, you can only have one head of department only in the academic institutions. Then it came into like your MO grade 3, it's like it ends like a first entrance specialist. Then that's when we realized that the MO grade 3 has got 10 years. The first entrance specialist has got just an entrance, but they are earning almost the same salary. That's when we realized it's a bit of a discrepancy. And then there was also an issue of the heads of clinical units, which at the present moment, you only need 3 years to be a head of clinical unit. But at that point as well, you realize that you don't need a lot of heads of clinical units. You only need 1 per department. And then from there, what they did, when you are a specialist grade 3, you actually earn less than a head of clinical unit. Well, while the specialist grade 3, you actually qualify only if you have got 10 years. So those were some of the discrepancies which we actually found. The other thing was when it was implemented, and thereafter, there was an issue of PMDS, which then they said, okay, as much as we want to give these people money, we must come up with how do we progress them from one notch to another. If you check, they're about close to 10 or 15 notches. You'll need almost, I don't know how many years to reach that all those notches. which is a difference of 1,000 or 2,000 rands. And most of the progression was done through what we call the performance agreements, whereby you have to perform at a certain level to be progressed to the next level, which at the end of the day, they didn't actually talk to most of our doctors, like I've already said, even the medical officers as well, the career medical officers, and also the specialists. So at the end, we're actually shortchanged. We're only, like I said already, it only addressed the interns and the heads of departments, because you have one intern is on a contractual basis. And then we realized that not most of the time, and then when we're actually trying to bring it to their point, they were saying that at the end of the day, there's no money. We've got a bloated public service. OSD, then it became a political issue for almost everyone. Even the politicians were not happy about it. And then now the issue is, then there was an issue of overtime, which was also introduced. Overtime was always there, but we realized that the overtime, it's actually your main salary. If today you actually take an overtime out from a basic salary of a doctor, you are left with nothing. So at the end of the day, that's we feel that this were given, we're not actually, we didn't actually see what was coming. However, SAMA came with a lot of studies to do comparative things and all that, but it was never taken into cognizance. We only promised that the government will always address it. Even today, that's why today even doctors are saying, let's forget about the overtime, because if you want to threaten the livelihood of a doctor, talk about taking the overtime away, which is always going around all over in the country. Limpopo, I mean, here, even in Gauteng now, they are saying they want to cut it, others want to reduce it. There are so many things which are involved. So at the end of the day is OSD, yes, it was implemented. From our side, we thought it's a good intention to retain and increase our salaries, but now we realize that it has got a lot of shortcomings because it didn't address most of the things that I've already said.
No, thank you. Thank you very much, Dr. Mawea. Who would forget the strike in 2009? And I must say that some of us were still students in 2009. And when we joined as doctors in 2010, we thought that we were earning a lot of money. We only realized later that actually when you become a medical officer, this amount drops. Thank you very much for that. That was very insightful. And just quickly to take us through now the salaries, the analysis of the salaries themselves, I would like to hand over to Dr. Sandile Mhlongo. Dr. Mhlongo is the Managing Director of Curis Health Solutions. Dr. Mhlongo, please take us through. The floor is yours.
Thank you very much, Dr. Nodigita. I appreciate the opportunity. Let me actually just start by thanking South African Medical Association for inviting us to participate, firstly in this webinar, but more importantly in the analysis of income for medical professionals in the public sector. We were really honored, but this our participation here is really because this is such an important aspect of strengthening healthcare systems. And our healthcare system is entirely dependent on the health workforce. And that is what the WHO speaks about, that actually at the core of the health system is the health workforce. And we all know that without doctors, the health workforce also is non-existent. So it was actually an interesting exercise to go through this analysis over a number of months to see what has happened to doctors' income. And I'm actually very interested in some of the comments laid bare by Dr. Mawea. I remember when I was still in the public sector in 2009 when we downed our tools. So this story actually has a lot of components that actually affect our livelihoods, the well-being of doctors, and also the doctors' impression of how they are valued by the society that they serve. I do think there's a lot that still needs to be done in terms of really doing deep dives. We didn't really get through to compare how doctors fare in relation to other professionals of a similar rank and level, or how they fare internationally. I think those are things that we still need to understand, because this partly informs migration out of the healthcare sector into the private sector. out of the country into international countries, as well as other challenges in terms of career changes. And we see quite a lot of professionals who leave not because they want to leave clinical medicine, but because the value that, or they feel undervalued by the healthcare system. Without wasting too much time, I will actually share a few slides with the audience today. And just from our point of view, what the findings were. And perhaps we'll then get into a deeper discussion. This is a very, very summarized version of the findings of this analysis. As I said, it took us a number of months, and to Dr. Mawea's point, there's about 16 different grades of medical officers, and then there's another 12 of different specialists and so on and so forth. So it wouldn't be sufficient to really present that in this forum, but I think it would be worthwhile for the audience to just look at the entire content and understand exactly at different grades and what really has happened. But the findings are quite consistent in the main. So I think what we will share today is quite informative. Perhaps not really specific in terms of the numbers across the grades and different categories of medical officers, but quite informative in terms of the trends and actually what are the important recommendations and principles that need to be followed in addressing what we see as shortcomings. So I want to start by just something that's actually an important principle. In any environment, when we researched this, particularly for healthcare professionals, there were 6 things that came out in the research that really inform job satisfaction for medical professionals. And the reason why I wanted to start here is that actually the salary is an important component, but it isn't the entirety of it. And when we talk about job satisfaction, and we need to look at the broader context, we need to look at the attractiveness of the environment, how doctors are employed, and of course then income. And what we found in the literature is that income actually ranks number 3. But the working context, prestige and recognition, as well as working in actually where they really feel they add value, those are important aspects of what needs to be addressed. And we talk about this because that is part of the principle that it's not only that we need to address salaries. Yes, this conversation is truly underpinned by the salary conversation, but I think we have to actually just raise these issues to the surface around when we talk about security issues for female doctors and interns working in the night, especially in rural communities. We've seen a significant trend in terms of safety issues, security issues, lack of direction and support and supervision, as well as what Dr. Mawea was touching on, performance appraisal that actually leads to promotions. A lot of times those are unclear principles, and therefore when one then is looking at the salary component and the lack of the other supporting environment, it becomes actually quite a dire situation. And it's no surprise that actually there's a significant discrepancy in terms of the of preference between working in the private sector versus working in the public sector. Just to touch on the global trends, because I think this also informs some of the findings and how policies are formulated globally as well as in the South African, because we don't exist in an island, we exist in a global economy. So we see that actually the global economy, as we all know, went into a significant recession in 2020. There was a rebound growth at 6.1% in 2021, but 2022 showed again a slide back with a minimal 3.2% growth globally, and 2023 is projected to grow between 2 and 2.7%. And in South Africa, we know that the Reserve Bank has revised growth targets to about 1%. And if you look at
Dr. Sandile, we can't see your slides. Are you sharing?
You can't. I am. My apologies. Let me just try and share again.
Yeah, we unfortunately can't see them. Just go to the green button there, the bottom.
Yes. Is that showing now? All right. I apologize. I need to click one more.
No, that's
all right.
Go ahead, Dr.
Thank you very much. What we see here in the second box is, of course, inflation rates, particularly in emerging economies, which South Africa is one, have been significantly high over the last few years. But also, if you see the delta between developed economies and emerging economies, you can see that there's a widening gap. And the peak at 2022 at 9.9%, and in South Africa, we peaked at around 7%, close to 8%. Wage trends, I think what we found in the International Labour Organization publications is that wage trends actually have been under pressure, particularly in developing economies, not just because of COVID. You can see that globally, the last year of increase was really in 2013. And so from then on, wages, particularly in the healthcare sector, have been really coming under pressure with effectively a reduction in income for most medical professionals across the globe. What we do here, though, from National Treasury is that there's a bloated public sector wage bill. This slide in box number 4 is from the OECD, which is not necessarily untrue. The public sector is actually quite huge in South Africa, but one does need to interpret this in context. Number one, the public sector in South Africa plays a significantly big role in delivering healthcare services and just general services, as opposed to comparing to developed economies, which really rely on the private sector. So this is not always a fair comparison to say there's a bloated public sector. One must interpret that in context. But also what I think is important is noting that with all of that, especially if you look at the supply of doctors in South Africa, this slide I wanted just to show, this is actually from the WHO. If you look at the supply of doctors globally, South Africa has 8.1 doctors per 10,000 people. We sit in the second bottom quartile in terms of doctor supply. So when we really talk about doctors and we do international comparisons, we need to also understand the working context, the working condition, the demand that is placed on doctors, and also the relative infrastructure and conditions that they work under, to then really come to what would really be a fair comparison. So you can see South Africa sits right here, what I've highlighted in the red, and right at the far end, which is Cuba, at 84 doctors per 10,000 population. So we still have a lot of way to go. I think that we are slightly above the median. We are actually slightly below the median at 20 doctors per 10,000. So we are at 8. In fact, we are half of the median. So we don't even make up to the average supply of doctors per 10,000 population. Going back to touch on what has actually really happened in inflation in South Africa, you can see that pre-2021, pre-2020, in fact, we were really on a downward trend. You can see the moving average there in red on the right side of the screen, that the general trend was there was really an improvement in the inflationary pressures in the general population until COVID happens. And you can see then on the right side of the slide that once COVID happened, we've just been on an increase. So the consumer, including medical doctors and other healthcare professionals, have really been bearing the brunt of the aggressive inflation, among others, with supply chain constraints, and obviously the decline of the rand against the US dollar has also meant actually the rand is coming and inflation is coming under significant pressure. As I said, how public sector wage setting in South Africa is informed is really on the tenets of just really 4 principles. One, National Treasury always tells us that there's a bloated public sector wage bill, so that needs to be drawn back. There's significant unequal income distribution in South Africa, and we know that social spending priorities obviously come under pressure. And in general, the recommendation is that there needs to be a reduction in terms of the expenditure. And we see that even from international organizations like the IMF, the World Bank, when they engage policymakers in South Africa, that there needs to be a contraction of the public sector wage bill. And I think, as I've commented already, this is a misinformed or misguided presumption, because we are comparing apples and oranges in saying that in South Africa, where a lot of people depend on public sector services, the public sector shouldn't necessarily therefore be big to accommodate the demand placed on the populace on what the public servants do. The next thing I want to show is actually what also we get told when policymakers are talking about inflation and how it affects different sectors of the economy. Here, I wanted to show just 3 countries what the impact of inflation according to expenditure deciles. So if you look on the left of each of the graphs, you'll see that those are low income earners, so therefore they tend to spend in the lower deciles. But what you see in almost, especially the first 2 graphs in Mongolia and in Spain, low income earners tend to be significantly negatively affected by inflation. Whereas in Switzerland, you can see that middle income earners rather take the bear of the brunt. In South Africa, though, it's a very different picture. And I think this is also important when we actually engage policymakers in relation to wages. South Africa's actual, because of the makeup of the CPI basket, you see that actually high income earners and doctors, meaning even interns sit at D7, they get massively impacted by inflation. So when the inflation as it is right now is at its peak, you will note that actually the people who really truly bear the biggest brunt are actually the people at D7, D8, D9, and mostly D10. So this obviously why I wanted to show this slide is that actually we must understand that actually the negative inflationary or the high inflationary cycle that we are going through means it's actually taking income from doctors even more than what we would have expected. So the key finding that that I'm going to go through in the rest of the slides is really just these 2 graphs. Number 1, what we're seeing on the left is that in real terms, there hasn't been any growth. So the blue line on the left side of the graph, on the left graph, is showing that actually relative to inflation, there was a consistent increase in doctors' salaries up until 2020, where there was 0% adjustment. And then in 2021 and 2022, there were minimal corrections for inflationary adjustments. So any gains that would have been had by doctors between 2012 and 2018 have been immediately over the last 3 years decimated. So effectively, in real terms, the line in red on the left graph is showing that in real terms, doctors are earning exactly what they earned in 2012, more or less 2012, 2013, without any increment. And the actual loss in nominal terms, so in other words, while the adjustments were making up for the inflationary pressures up to the year 2019, what has happened over the last 3 years is that we've decimated any gains that doctors made. So you can see that on the right graph, there's an inflection point at 2019, and there's a massive area under the graph below the 0, which means any income especially for the long-term medical officers or long-term servants of the state, that any income that they would have gained or any surplus that they would have earned over and above inflation has been decimated in just 3 years. So the average doctor today earns 13% below what they should be earning in real terms. I'm just going to quickly go through the segmental analysis. As I said earlier, we didn't bring all of the different levels. We just targeted 4. I think the theme is more or less the same. And so what we are seeing here, I just want to quickly run through the interns. We see that, as I said, the real-term income growth has not happened or has been lost since 2019. So interns are exactly where they were in 2012. And you can see that the expected in the red line shows a 13% deficit. So per annum, interns are earning 40,000 rands below what they should be earning per year today. And we see a similar pattern for medical officers, equally sitting in the real terms on the income analysis slide. You can see that they are effectively earning 60,000 rands per annum below what they should be earning, and the expected line in graph number 2 is showing a massive difference of 10% between where they are and where they should be. Similarly, a similar trend, I'm not going to go through the detail here, but for registrars we found, I just want to explain, perhaps in the first graph, you can see the dots there show the differences between the highest earning registrar and the lowest earning registrar. So it's not really that much of a difference across the 4 levels of registrars that we see. But again, registrars are about 70,000 rands below what they should be earning per annum, and there's a 9% deficit. We then focused on the specialist grade 1, and maybe to Dr. Mawea's point, you can see that actually the gross income for specialists and registrars doesn't really differ that much, which then speaks to the issue of OSD. So while we're talking about the inflationary changes and annual adjustments here, we actually can see that the baseline salary as well has not really been addressed sufficiently, such that there's sufficient differentiation between different levels of jobs and different levels of specialization. So what we are seeing is really that, if I just want to hop one slide back, that the registrars peaking at about 900,000 rands aren't really that different, with specialists peaking at about 1.1 per annum. So there's about only a 200,000 rands difference between a specialist and an average registrar. So what we're seeing here, as I wrap up, is that actually the average doctor is about 12.6% below where they should be earning in the public sector. And what we've modeled here on the right side of the screen is actually what we think should be the correct adjustments. So in the red graph is really what doctors would prefer to go home with, because this really addresses the 0% increment that was granted in 2020, as well as the sub-inflation adjustment made in 2021 and 2022. So therefore, there should really be about a 7% increase per annum over the next 4 years. That's what we model and we project should be the engagement with the public service in terms of salary adjustments for medical professionals. The last part that I just want to touch on, and perhaps it will come back in the panel discussion, is one of the realities is that it's not that this is just about income, but when there isn't actually proper remuneration for medical professionals, the literature is really full of cases and other policy shifts where there's either an increase in dual employment, what we in South Africa refer to as RWOPs, where doctors have to spend time in the public sector as well as running general or private practices. There's an increase in absenteeism, but also we see predatory behavior. So when we see that, we should understand it in context of the underlying policy shifts that are directing people to do what is incorrect. But at the end of it all, the population suffers. Society is what pays in terms of negative health outcomes, because as we can all understand, if absenteeism is high in medical professionals, therefore, who's seeing the patients? And so therefore, when we see medical errors, and what is quite interesting is that most provincial departments are paying in billions in medical errors and litigation costs, but that could easily be redirected to remunerating professionals and other healthcare workforce appropriately, so that there's an increase in workforce availability, as well as actually the quality of care that they deliver, as also other conditions of employment that actually make people feel proud of the job that they do and the contribution to society. In my last slide, just as I wrap up, there are 4 categories of things that really need to be addressed. 1, career development for medical professionals. Public sector infrastructure improvement needs attention. Resource availability, not just medical doctors, recognition for contribution in terms of what people do in their jobs, but also financial incentives being very important. I think Dr. Mawea touched on something that's very critical, that actually the non-pensionable overtime that doctors earn makes up about 30% of their income. That actually is not sustainable, because people should work overtime only as if they choose to, not because it's an absolute necessity. So we can't staff departments with overtime. There was a paper that was published by the ILO in 2017 after a survey in Groote as well as Tygerberg Hospital, where interns and medical officers were reporting working close to 100 hours a week. And we know that actually those conditions don't actually bear well for their own mental well-being, their physical well-being, but also for the quality of care that they deliver. And in the end, we do need to address the gaps in OSD, as well as actually just addressing the current salary deficits that actually have been granted to medical professionals. Dr. Nodigita, this is my last slide. Thank you very much.
Oh, thank you very much, Dr. Mhlongo. I think this is very, very important information that you've brought to our attention. And it will receive the necessary attention that it should get from the Medical Association. Without wasting time, we're now going to move on to Dr. Pikicha, who is a sub-board member, and will give us the practical experiences of doctors in terms of their salary adjustments over the last 10 years. Dr. Pikicha, the floor is yours. Thank you very much. Dr. Pikicha, please unmute.
Hey, can you hear me?
Yes, now I can hear you loud and clear.
All right. Okay. Good evening, colleagues. So I'm very honored to have been invited to join and address you, colleagues, on the issue of our salaries and what we have come in terms of analysis and the road down from OSD and its initial phase. So I've been tasked, as I've been introduced by Dr. Nodikita, to actually now bring it to the practical side, where we discuss how then this actually reflects to a doctor on the ground and the practical implications of it. So if you'll see on page 1 of the slide currently being shown, I've decided to address commuted overtime, which is going to be the focus of my talk, because I feel that is the crux of the matter, where we've hyperinflated our salaries to make it look like they are comparable, whereas they're not. So I'm going to be dissecting this portion of our salary, which is COT, which makes up the bulk. So that is what I'm going to be addressing. Next slide. Okay, so to start with, when we're discussing commuted overtime, in terms of what is defined with commuted overtime, it's actually then something that is able to be entered into by medical and dental practitioners that are registered with the HPCSA. I know most of the time we've only been talking about the medical component, but it does make space for the dental component as well. This is only available to those that are entered into a full-time contract with government. So for those that are doing the part-time or sessional work, as we know, they then don't become eligible for this component of pay. Then it also must state that it includes interns and community service officers as well, as much as they are on contract, but they are included in this COT dispensation. It also must be noted that when we're talking about COT, you're talking for compensation for working over the 40 hours that you've legally entered into, which then makes up your basic salary. So this is anything after the 40 basic hours that you should be doing per week. And what it is, and I'm hoping that this has now become uniform across the province, we are talking an averaging of overtime over a consecutive 6-month cycle. So this is with the understanding, obviously, that people go on leave. The fact that we've agreed that it's commuted means that we understand that from month to month, there might be variations depending on the floor, but it should then average out over a consecutive 6-month cycle for the person then to be considered adherent. And also to note that this is now also determined by the clinical needs of the department. So in a nutshell, those are the components that make up COT and what then defines it. Next slide. Okay, so then with overtime, it's broken down into 4 groups, commuted overtime. So in your group 1, it's going to be those who choose to do a category of an additional 1 to 4 hours per week. So just remember, colleagues, that we're talking in addition to the 40 hours here. So group 1 would be doing 1 to 4 hours per week. Your group 2 are those that would be doing 5 to 12 hours per week, which would obviously be commuted at a pay rate of 8 hours. You then have group 3 who have then signed on for 13 to 20 hours, which is commuted at 16 hours in terms of pay. And you then have group 4, where you have a performance of more than 20 hours per week, but this is also then subject only to prior approval by HOHs. So it's not something that's offered in terms of contract. The group 1, which is the 1 to 4 hours per week, and the group 4, which is the more than 20, those are paid out on a claims basis administratively by the HR department. But when it comes to group 2, which is the 5 to 12, and group 3, 13 to 20, those ones you would find just being paid as a monthly allowance with your salary. So those ones are captured into your PERSAL. You then have your HOUs, who we do have to make a special note about them, because HOUs then are restricted strictly to group 1 and 2 in terms of the commuted overtime that they can qualify for. Okay, next. You then also have the management component of what is COT, because remember that we do have those that are running at a management level, whether you're a head of clinical unit, you're a clinical manager, you're a head of department, CEO, all of those are then considered under the management portion. They then, if they are clinically qualified in terms of what or who you should be to get into overtime, they are allowed to do COT themselves. And this, though, must be noted that they only get paid for clinical work after hours. So you could not be doing administrative work after hours despite your managerial duties during your basic hours. And this may be performed up to group 3 for management, but we did note that it's HCUs and HDs, like we said in the previous slide, can only do up to group 1 and group 2. These also need to just follow the normal processes, but must be approved by the supervisors, so medical managers, CEOs, district directors, who then would approve that this overtime is necessary. And with this group of management, there's been a special dispensation that they are able to do their overtime at other institutions. This is also in some cases to manage conflicts and ethical dilemmas where you've got a CEO of a hospital then having to perform those duties in their own facility. So they are given that dispensation of being able to go to other institutions, but this would then need to be approved duly by facilities to say that this overtime is indeed warranted. Okay, next. They are now this is where we start getting to the part that starts affecting us on a daily basis when it comes to the COT policy, the exclusions. So when you're dealing with COT, all those that are not on full-time employment and are part-time are then excluded from COT. So that's all those that hold sessional or part-time posts. They would not be able then to take part in COT. Those who fall under clinical associates, they also are unable then to get into COT. Then, unfortunately, COT cannot be paid during specific types of leave. So if you're on sabbatical leave, if you're on maternity leave, if you are away on special leave, if you're on family responsibility leave, if you are on sick leave, all of those cannot have your COT paid out during those times. But having noted that, it then takes us back to the statement that I delivered earlier, that because we're looking at it in a 6-month consecutive cycle where it must end up commuting, if they are able then to fulfill those hours within the consecutive months, they then can be paid out if the leave had affected them. So all of those leaves, unfortunately, cannot have any form of COT paid out during them. And we then also have certain specialities that have been excluded. So this may also vary a little bit depending on the province, but occupations such as public health, occupational health, genetics, and others have been excluded as well from being able to take part in commuted overtime. The basis of this then being that it's based on clinical need. Okay, next. So I've said all of that just to give a background, colleagues, on COT, how it's applied and who can do what. And now I want to just round up what are the implications of all of this. So firstly, you're going to have to deal with the fact that because it's contractual, it is renewable on an annual basis. So this means that you may be a full-time permanent employee, but the COT portion of your salary is actually contracted and renewable on an annual basis. And if you couple that with the fact that it's need-based, it means that you could find yourself in the next financial year not being offered COT. I think we've seen case in point in Limpopo, where you have full-time doctors, but they then suddenly were told, okay, things are going to change and needs need to be looked at. So you'll find yourself now having that portion of your salary not necessarily being offered to you anymore. So that's where the annual contract becomes a problem. And the fact that it's needs-based as well then exacerbates that. The fact that it's also non-pensionable also has a huge impact on what happens, especially if you are a career in the Department of Health. This therefore means that the Department of Health is not contributing towards your GEPF for that portion of your salary, which then you must understand has impact on what you're going to end up being paid out as a GPF amount, and based on what you were earning, it's going to impact that you'll only be given contributions on the other basic part, not on the overtime. So you can understand the pay disparity and how it'll impact you at the point where you need to retire. Then there comes the contradiction that as much as it's non-pensionable, it is, however, taxable. So it has unfortunately increased our tax bracket to the point where we are not even qualifying, most of us, for any government contribution in terms of things like your medical aid, but unfortunately it's pushed you into the higher tax brackets. So you now have that kind of dilemma where it's non-pensionable, but it's taxable, and it has driven you out of receiving a lot of benefits based on the salary band that it now puts you in. We also need to look at what everybody knows, the fact that the overtime has been used to overinflate our salaries. You'll even see that when there is an advert that is put out, that advert is put out basically also with a COT portion. So it almost looks as if it's something comparable where it's not. And when you look at how much do you actually end up earning, when you look at your COT and compare it to being a percentage of your basic salary, you are looking at it actually being somewhat of 45 to 50% of your basic salary. So that is a huge amount of what the overtime contributes to your salary, as much as it's non-pensionable and unfortunately as much as it's taxable. You then have the problem where, because of what I indicated, that it's not payable during certain leaves, you then suffer, especially during your incapacity, where you've exhausted your sick leave days, or during your maternity. Because unfortunately, during those times, it's not going to be possible for you to end up commuting over that 6-month period simply because of how long those leaves are. So it means that during the time when you need it most, during your maternity or during incapacity, where you've got higher medical needs, you will now be suffering a loss of about 40 to 50% of your salary. Now, all of this has had an impact on us in the government sector, in the fact that it's encouraged RWOPs. Now, people look at RWOPs as the only alternative to be able to supplement their income so that they're able to meet inflation, so that they're able to, get their basic needs, day-to-day needs met. Because remember, inflation is affecting every other area of your life, but as was shown earlier, that it has not caught up with our salaries. So people then view RWOPs as the only way to be able to supplement this. And we all know that we've had now the bad practices where you have people deserting the government patients and going to see private patients during the time that they should be attending to the patients in their institutions. We then have people overworking themselves and not being able to rest adequately in trying to make sure that they are able to pick up, the extra salary that they need to compensate for this lack. This obviously then has huge impact in what we look at in terms of medical negligence, because if you're looking at supervisors not being there, it obviously means that juniors are left to run the facilities, meaning that now more mistakes can be made in that regard. If you also then have employees that are overexhausted, that are not getting time to rest and recuperate, they are not going to be making clinically sound decisions, and you then will have an increase in medical negligence, particularly where you are looking at your surgical disciplines. You then also have the issue that is known to everybody, the fact that there is going to be a problem with retention. This retention will not only speak to the public sector, but will also speak to the profession in South Africa as a whole, because it's almost become impossible to live solely in the public sector and not be in private as well. So you see others looking at more lucrative deals from other countries that are headhunting and seem to be able to give them a very market-related and competitive rate for their services. So as South Africa, we then hemorrhage, which exacerbates the scenario, and we are short-staffed, meaning that we now end up with fewer people ending up to now go to the max spans of these groups to be able to cover the floor. So it's almost a vicious cycle that we enter into when we have the complications of all of the COT. Okay. So colleagues, I'm hoping that I've been able to give a picture of how that COT component is actually relating into the practical implications for your pockets, but also how it is actually impacting the medical field in terms of the staff, the morale, medical negligence, and retention of physicians in the South African service. So hopefully that's given a practical flow example of what it means to have the bulk of the salary actually coming from the COT component.
Thank you very much, Dr. Bikicha.
Thank you.
Dr. Bikicha? Thank you very, very much. And thank you to the other colleagues. We have now arrived to the Q&A session of our webinar tonight. We've got about 3 questions. I must apologize, colleagues, that time is an enemy here. We will not be able to reach everyone, but we will take Daniel Lowe, and I think Dr. Sandile Mhlongo would like to answer that question. I think Dr. Bikicha might have to deal, or Dr. Mawea, and then Dr. Bikicha can deal with the third one. The second one will come from Swela. We're coming to you, and Dr. Swaran will also come to you. So Dr. Sandile Mhlongo, Daniel Lowe is actually giving a comment there that the medical legal extortion is the single most existential threat to the entire medical profession, which is true, and clinicians' well-being. Some and all clinicians forum need a united front against this greed-driven aberration. If we can have a safe environment to practice it, then monetary remuneration can have a less critical role in our quality of life. Dr. Mhlongo, I would like you to maybe get in here and try and respond to this.
Thank you, Dr. Notikita. So to an extent, I want to agree with Daniel. One, as I said in one of my opening slides, the monetary component of any remuneration is not the be it and end all of remuneration or at least satisfaction within a job environment. And it goes for any job. It's not just limited to doctors. So that is important to understand. What I highlighted earlier on is it's important to understand the general working conditions, the environment that doctors work under, understanding, recognition for their performance, understanding, other elements in terms of, what rewards people for just if they feel good. Of course, we get salaries 12 times in a year and we work 240 odd days in a year. So there's that understanding that needs to come in there. I do think you're highlighting a very important point, but one does need to think about the issues that breed about what we're seeing in terms of the medical legal extortion. Yes, there are people, I agree with that, and there's been a lot of work that has been done through investigations to actually, there are people who are soliciting nurses, patients, and so on, just to ensure that they extort the healthcare system. But some of the contributing factors are the condition of service. And if you can improve the condition of service, I think Dr. Bigitsha highlighted some of the issues, especially as we drain more people out of the public service, and be it with dual employment or RWOPs, or people are leaving to go and work in the private sector environment. Therefore, that means there's less supervision, there's less people available, and accidents are going to happen. And so it's a systemic issue that needs to be addressed. And I do think improving the conditions of service, including salaries of professionals, the healthcare workforce in its entirety, as well as other conditions of service, including infrastructure, will go a long way to address some of the issues that we see. Therefore, even if there were extortionists, if the system is designed to be safe, if you look at the IOM report, even going back to 1999, the IOM report was very clear that actually errors in medicine are not necessarily what you see at the coalface. It's usually system-driven processes that are failing behind what you see up front. So there has to be a systemic approach to addressing what we see with medical legal extortion, and of course, making sure that the environment in which clinicians practice in is safe, there's sufficient supervision, there's enough availability of medicine and other resources to ensure that safe patient care is delivered on an ongoing basis every day. Thank you.
Yeah, thank you very much, Doc. Thank you. I see that we've managed to answer Siwela online. So we're going to deal with Swaran. Swaran is asking Dr. Bigitsha, what group should senior consultants be placed in terms of the COT? I think, Dr. Bigitsha, when you answer that, also just answer Dr. Kubega, who's asking, what is the logic behind the COT not taken into account regarding retirement? Why? What is the logic? Why is it not pensionable, but it's taxable, and increasing our tax bracket? So if you can just deal with those. The other one is just praising you that it was a great presentation, which I agree. Very, very well-structured presentation that you did there. So yeah, can you deal with those quickly? Then we'll deal with the last three. Thanks.
Okay. No, thank you. Am I audible?
Yes, you are. Yes, you are.
Okay. Thanks. Let me start with the first question, which deals with the senior consultants. So senior consultants technically, if they are just in a consultant role, not in an HCU role, a head of clinical unit role, and they just a senior consultant, they are able to take all the way up to grade 3. So they can sign up for grade 3 if they wanted. So that is able to be done. But where the challenge comes is that does not necessarily speak to what they do on the floor, because we all know of the challenge of people that are doing their course from home and are not necessarily the people that are seeing the patients, clerking and doing the operations at night. These would tend to be done by the junior category of staff. So when it comes to your specialist, they then can qualify up to grade 3. Now, the argument from their side also could be the fact that because they need to cover and there are so few of them as specialists, they actually, as a trade, have almost ended up just accepting the fact that they do well beyond what should be covered when it comes to grade 3, because there's fewer of them, but the month needs to be covered. So that's where the catch-22 is, in that they are able, and most of them do then get signed up to grade 3. And it's with the understanding that they might not actually even be the ones on the ground, but they also do provide the coverage for the entire month. So that's where the dilemma is, to say that what are we saying at the end of the day, because we're paying for somebody who's not, but at the same time, you don't have enough specialists that if they were to stick strictly to the commission, you would have a crisis when it comes to senior specialists providing clinical services. So that's the reality of the situation. So ideally, what you'd want is that we are able to produce more specialists so that we would not be in that situation. But you'd also need to find a hybrid model of how you can work this, so that it's understood that some places are not going to be cookie cutter, where you can just put the policy and apply it. I'm hoping that addresses that question. Then we can go to the next question, where it was the issue of what is the logic. I must say that this was very well played by government, because you know, when you are wanting OSD and you're looking just at the end figure, which is what I think was one of the mistakes we made. But they found I'll say, what do they call it? The terms and conditions, you know, the fine print. And this fine print has seen them been able to recuperate a lot of that money through taxation, but make sure that they are not liable when it comes to government contribution for our tax. So it's very well played on the behalf of government, which is why we all agree that what we now need to do is come back and say, we are fighting for a livable basic wage. It needs to be a basic wage that is comparable by itself to what our peers on the market are receiving. Because if you remember, overtime is not something that is considered pensionable. So unfortunately for us, it was fine print in getting us that bigger number that we wanted. But we now have realized that the fight needs to be for a living basic wage, not one that is just artificially dressed up.
Yeah, no, thank you very much, Dr. Pikisha. And colleagues in the webinar, I will not be able to get to all your questions. Time is an enemy here. As we get to the close, we draw to the close this webinar, colleagues, I would like to just emphasize the critical role that doctors play in the public sector, in the South African health system. The findings of the study that has been presented to you by some have illuminated a stark reality that these dedicated professionals are indeed underpaid. This is a challenge that we as an association cannot overlook because of its far-reaching implications, not only to the individual doctors themselves, but to the broader community. The recommendations proposed in the study are not mere suggestions, but I call to action for us. Urgent reforms are needed to rectify these disparities in salary adjustments, to ensure that doctors are fairly compensated for their invaluable contributions, to create a supportive and a motivating work environment, While financial remuneration is a significant aspect of this issue, the study also underscores the importance of non-financial incentives, mental health support, work-life balance, and opportunities for career advancement. Addressing these aspects comprehensively is essential to building a health system that can not only attract and retain its vital workforce, but also delivers high-quality care for all South Africans. And in closing, colleagues, the summer study has shed light on a number of critical matters that demands our immediate attention. The well-being and the dedication of our medical doctors are at stake. The health system's effectiveness hinges on their satisfaction and motivation. Let us take these findings to heart, advocate for change, and work collectively in line with the summer motto of Uniting Doctors for the Health of the Nation, to create a healthcare environment where our doctors feel valued, supported, and inspired in their noble mission to heal and serve. These findings will be discussed with the relevant stakeholders by the association and used as a basis for future salary negotiations. Thank you very much for your participation in this webinar. And let us carry forward the spirit of change in being united as doctors for the well-being of the nation. I thank you very, very much.
Thank you, Chairperson.
Thank you so much, colleagues.